So now we will move on to the prototype of the hyperthyroid disorders, which is the Graves' disease. So Graves' disease is overall the most common cause for hyperthyroidism. So as you know, Graves is an autoimmune disease where due to the result of an autoimmune process, there is autonomous production of thyroid hormones from the thyroid gland. And the hallmark finding of Graves' disease is the presence of TSH receptor antibody. So TSH receptor antibody is the pathognomonic finding which is present in patients with Graves' disease. But because TSH receptor antibody is the cornerstone in the Graves' disease pathogenesis, it doesn't mean that humoral immunity is solely responsible for its genesis. In fact, the cell-mediated immunity is primarily responsible for the pathophysiological alterations seen in Graves' disease. So, cell-mediated more than humoral immunity. So, even though TSH receptor antibody, or what we call as TRAb, is exclusively present in Graves' disease, so cell-mediated immunity is more important than humoral in a patient with Graves' disease. So, how does Graves' disease occur in a patient? So, when a genetically predisposed individual, so genetic predisposition will be present. So, when such individuals are exposed to certain environmental factors, so we will see what are the genetic factors and what are the environmental factors. So, the genetic factors include several genes which regulate the autoimmunity, like the autoimmune regulatory gene, PTPN22, CTLA4, so interleukin 2 receptors. So these are certain genes which regulate the immune functions within our body. So for example, this CTLA4 prevents the T cell activation. So is PTPN22. So autoimmune regulatory gene, or AIRE, is responsible for cell tolerance or immune tolerance. So when these mutations occur in these culprit genes, it can result in the dysregulation of the immune function within an individual, causing an increased risk of autoimmunity. So in such genetically predisposed individuals, there are certain environmental factors. So what are the culprit environmental factors? It could be infections. So the infections which increase risk of Graves' disease include Yersinia enterocolitica, then HCV infection, H. pylori infection, etc. Then certain drugs, certain environmental toxins, then iodide excess. As you know, iodine deficiency will result in goiter, whereas iodide excess can precipitate autoimmunity in a predisposed individual. Smoking. So such various environmental insult can precipitate the underlying inflammation in a genetically predisposed individual, and that is the reason why eventually Graves' disease will occur. So as we have already mentioned, the hallmark finding is the TSH receptor antibody, which result in the symmetric stimulation of both the thyroid gland. So the radioactive iodine will show a diffuse uptake in both the thyroid lobes. So essentially what is happening in Graves' disease is that this TSH receptor is present in many cells in our body. So it is present in the thyroid follicular cells, it is present in the orbital fibroblast, it is present in the fibroblast in the skin and subcutaneous tissue, present in melanocytes, bone, etc. So this TSH receptor is not confined to thyroid alone. It is present in other areas of the body. So what happens is that this TSH receptor antibody in Graves' disease has a stimulatory nature. So it can activate the TSH receptor. So what happens when there is activation of the thyroid follicular cell? There will be hyperthyroidism. What happens when there is activation of the orbital fibroblast? So that will result in increased glycosaminoglycan deposition, increased orbital myofibroblast. So all these changes will predispose the individual to develop orbitopathy, thyroid-related orbitopathy. Then fibroblast in skin and subcutaneous tissue, when they are stimulated, that can result in dermopathy changes. When melanocytes are stimulated, it results in its proliferation and melanin production, resulting in hyperpigmentation. So this is the basis for the multiple extrathyroidal manifestations that you associate with Graves' disease. So contrary to other causes of hyperthyroidism, Graves' disease is unique that it produces a specific subset of extrathyroidal manifestations, namely thyroid orbitopathy, thyroid dermopathy and thyroid acropathy. So it produces thyroid dermopathy, thyroid orbitopathy. Orbitopathy is also known as thyroid ophthalmopathy and thyroid acropathy. So acropathy means there is increased periosteal reaction in the extremity bones, and also there is increased risk of clubbing. So presence of clubbing and increased periosteal reaction in the extremity bones is what we call as thyroid acropathy. So this is the classical triad of the extraorbital features of Graves' disease. Now we will see the clinical features. So clinical features of Graves' disease is common to other causes of thyrotoxicosis. We have already discussed a multitude of clinical features which can be seen in thyrotoxicosis, which ranges from palpitation, tremor, restlessness, weight loss, diarrhea, excessive bone loss, etc. So all features of thyrotoxicosis can be seen with Graves' disease. And when you compare the Graves' disease with other causes of thyrotoxicosis like thyroiditis, some of the points has stood out. One is the presence of significant goiter. Presence of significant goiter. Second is a long duration of symptoms. And third is the presence of extrathyroidal features. So these are the three most important points that you should ask in the history regarding a patient with suspected Graves' disease. So goiter is present in around 70 to 75% of individuals. So it still means that around 1/4 of the patients will not have goiter. So if a patient with thyrotoxicosis is not having goiter, it doesn't rule out the possibility of a Graves' disease. Okay. Then extrathyroidal features, we have already learned there are a triad of features and we will be dealing with each of them one by one. So now coming to the examination in a patient with Graves' disease. First you have the head to foot examination. So in the eyes, you will have to look at the changes of thyroid orbitopathy. So which are the two most important features of thyroid orbitopathy? One is lid retraction and second is proptosis. And one important point to be mentioned is that the presence of lid retraction alone is not specific for Graves' disease. So why lid retraction occurs in thyrotoxicosis or Graves' disease is that it's not only because of the action of TSH receptor antibody. The sympathetic overactivity that we associate with thyrotoxicosis can result in the activation of the Muller's muscle. So it is a contraction of the Muller's muscle which is causing the lid retraction in thyrotoxicosis. So Theoretically, all cases of thyrotoxicosis, in fact, all causes of thyrotoxicosis can result in lid retraction, but the presence of proptosis is more specific for the diagnosis of Graves' disease. So, proptosis is more specific, whereas lid retraction is more sensitive. Then you can look for the other signs like the redness, pain, decreased vision, all things like that. So these are the things that you should look for in the eyes. And when you look at the neck, we have to assess the goiter. So goiter that we associate with Graves' disease will be diffuse. So as we have already learned, goiter is unlikely in a patient with subacute or silent thyroiditis. In toxic nodular goiter, it depends on the number of nodules. If it is a solitary nodule, we will be able to palpate that nodule in either the right lobe or the left lobe or the isthmus. Whereas in toxic multinodular goiter, we will be able to palpate multiple nodules. And one feature, characteristic feature in toxic nodular goiter is that the nodule size is usually very large. For example, the size is usually more than 2.5 centimeter to acquire the autonomous production capacity. So those nodules which are actually functioning will have a size of more than 2.5 centimeters. It is not applicable to 100% of the nodules, but that is the usual pattern that we see in practice. So the autonomously functioning nodules will have a 2.5 to 3 centimeter size. So even if a patient with suspected Graves' disease is having, when you look at the ultrasound of the thyroid, you are seeing a thyroid nodule of 1 centimeter, of 1.5 centimeter. It doesn't mean that the patient is having a nodular goiter, because nodules can be present with Graves' disease also. But only when the nodule size crosses a 2 centimeter or a 2.5 centimeter mark, then we will suspect the possibility of a toxic nodular goiter than a Graves' disease. But again, we have specific differentiating factors to confirm the diagnosis of Graves' disease. You can look at the TSH receptor antibody. If it is positive, you can confirm the diagnosis of Graves. Then you have the presence of extrathyroidal manifestations like orbitopathy or dermopathy. Then also you can confirm the diagnosis of Graves. And finally, you can do a radioactive iodine uptake study where the Graves' disease patient will have a uniform diffuse uptake of iodine, whereas there will be only focal or multifocal uptake of the radioiodine in thyroid nodular goiter producing toxicity. So there will be diffuse goiter in a patient with Graves' disease, and soft consistency is characteristic. So what is the normal consistency of a thyroid gland? It is termed as rubbery. So normal is rubbery consistency, whereas in thyroiditis, you get a firm consistency. In nodular goiter also, you can get a firm or even a rubbery consistency. So the typical soft consistency of Graves' disease is due to the increased vascularity, because this activation of the overzealous activation of this TSH receptor will result in substantial increase in vascularity within the thyroid gland, which is the cause for increased softness. But you have to keep in mind that all Graves' disease goiter is not soft, because if the patient has got a history of pre-treatment with anti-thyroid drugs, there is increased risk of fibrosis setting in the thyroid gland. So there the goiter will have a firm consistency. So if there is treatment history for Graves' disease either with anti-thyroid drugs or with radioiodine therapy, then the goiter may be firm. In an untreated naive patient with Graves' disease, then the most likely consistency is that soft consistency. Okay. Then no or small nodules. So of course, nodules can be seen coexistent with Graves' disease, but the classical picture is that there are no significant nodules. If at all present, the nodules are usually subcentimetric, And one important thing regarding the presence of nodules in a Graves' disease is that if you confirm the diagnosis of Graves' disease and you do an ultrasound of a thyroid, or even without ultrasound, if you are able to palpate a nodule within the thyroid gland in a patient with Graves' disease, you should do the ultrasonographic study, and if applicable, you have to do the FNAC as well, because there is increased risk of cancer in a thyroid nodule for a Graves' disease patient. So thyroid nodules are not very common in Graves' disease, but if present, then you should actively evaluate for the thyroid nodule to rule out the possibility of thyroid malignancy. Then, as I have mentioned, there is increased vascularity within the thyroid gland, and you may be able to elicit thyroid bruit. So, thyroid bruit is auscultated in the inferolateral margin of thyroid, inferolateral region of the lower thyroid pole, using Bell oscilloscope. And unlikely, this goiter is unlikely to produce significant compressive symptoms, but rarely in very large goiter you can get compressive symptoms in the form of dysphagia or breathlessness on exertion, hoarseness of voice, and very rarely retrosternal extension also, but which is less likely. So these are the 4 important points: the diffuse nature of the goiter, soft consistency, no or small nodules, and presence of bruit. So these are the 4 points that you should look at when you examine the goiter in a patient with Graves' disease. Then you have to examine for the peripheral signs of thyrotoxicosis. Peripheral signs of thyrotoxicosis. Starting from the pulse, you should see whether the patient is having tachycardia, irregular beats are there, the chance of atrial fibrillation is also high. You have to look for the apex pulse deficit which is present. You have to check with the ECG also. So the pulse, so blood pressure, also you should look at tremor and features of heart failure. Okay, so you have to look at the thyrotoxicosis, and finally you have to look at the other signs of peripheral signs apart from orbitopathy like dermopathy and acropathy. Acropathy is examined by the presence of clubbing in your fingers. So this is the image. So here in the first image, you can see in the right eye there is upper eyelid retraction. So you can definitely see the upper eyelid retraction here. Whereas in the left eye, the retraction is not very apparent, but there is retraction of the lower eyelid retraction. Here you can see there is apparent proptosis as well as retraction of both upper and lower eyelids. The image B, you can see the retraction in upper and lower eyelids. So you can make a diagnosis of Graves' disease without any sophisticated biochemical investigations like the TSH receptor antibody or the thyroid ultrasonography or the radioactive iodine study if you get the classical triad. So the classical triad in Graves' disease is what we call as the Merseburg triad. Merseburg triad, which is thyrotoxicosis plus goiter plus ophthalmopathy. So if this classical triad is present, then you need not go for other sophisticated investigations to confirm the diagnosis of Graves' disease. Of course, the other investigations will have a significant prognostic and therapeutic implications, but for diagnosis, if you have these 3 pointers from clinical and biochemical examination, then you can confirm the diagnosis of Graves' disease. Then a few points regarding Graves' ophthalmopathy or orbitopathy. So 70 to 75% will have Graves' ophthalmopathy at the diagnosis or within 1 year of diagnosis of Graves' disease. So that is the most common tempo of occurrence. 70 to 75% will have at time of Graves' diagnosis, at the time of thyrotoxicosis diagnosis, or within 1 year. So around 10 to 15%, the ophthalmopathy will precede the diagnosis of thyrotoxicosis. And in the other 10 to 15%, it will occur later, after 2 years. So in the first and the third scenario, your diagnosis is fairly straightforward because the patient is already having thyrotoxicosis and later on developing thyroid ophthalmopathy, or developing ophthalmopathy in the setting of a pre-existing thyrotoxicosis. So this one and this one is fairly straightforward. But what happens to this situation? So here, when the patient presents with proptosis or lid retraction, the patient is clinically euthyroid. So that can present with a clinical dilemma, because there are a number of conditions which can present with proptosis of the eye. It could be ranging from localized ocular pathologies, can range from the infiltrative diseases, even malignancies or granulomatous diseases. There are so many conditions which can result in the proptosis of the eye. So if the patient is clinically euthyroid or the biochemistry reveal normal thyroid function test, then you have to go for other investigations like TSH receptor antibody to confirm whether the ophthalm related changes is due to thyroid eye disease or not. Okay. And it is also worthwhile mentioning that around 5 to 10% cases of orbitopathy can be associated with Hashimoto's thyroiditis also. So 100% of thyroid orbitopathy is not due to Graves' disease. Around 5% can be seen in Hashimoto's thyroiditis also. So what is the mechanism for developing Graves' disease or Graves' orbitopathy like picture, or a thyroid related orbitopathy in Hashimoto's thyroiditis? The reason we have mentioned in the previous class, because this Hashimoto's thyroiditis has got several autoantibodies. The most common is the TPO antibody. Second is the TG antibody, and third is the TSH receptor antibody. So the difference between this TSH receptor antibody in Hashimoto's thyroiditis and in Graves' disease is that, so Graves' disease, the TSH receptor antibody has a stimulatory nature. It can stimulate the TSH receptor and result in activation. Whereas this TSH receptor antibody in Hashimoto's thyroiditis, which is present in around 20% of cases of Hashimoto's, is actually blocking in nature. So this blocking nature of antibody doesn't usually produce the stimulatory properties as seen in Graves' disease. But in certain subset of individuals, this blocking nature of TSH receptor antibody gets switched, so that the antibodies which was initially having a blocking effect now will be stimulatory. So such switching between the class and the bioactivity of the antibodies can occur, and this blocking antibody can become stimulatory antibody. So, and one particular thing to be mentioned is that this stimulation may not occur in all tissues. So if this stimulation occurs in the thyroid follicular cell, then in a patient with Hashimoto's thyroiditis, alternating hypothyroidism and hyperthyroidism can occur. When the antibody becomes stimulatory, the patient will be having hyperthyroidism, and when it becomes blocking, it will be having hypothyroidism. In between, just like the thyroid follicular cells, this change can be appreciated in the thyroid orbitopathy also, where the patient will be having increased proptosis as well as lid retraction in Hashimoto's thyroiditis. So I just want to reinforce that 5 to 10% of orbitopathy can be associated with Hashimoto's, and 90% of thyroid associated orbitopathy is bilateral, and 10% is unilateral. So important points to differentiate the proptosis due to thyroid disease from other causes of proptosis is, one is the bilateral nature of the disease, then the presence of lid retraction, and third is the presence of abnormal thyroid function test and TS receptor antibody positivity. So these are the ways with which we can differentiate the proptosis related to Graves' ophthalmopathy from other causes of proptosis. Now this is how we assess the proptosis. There are two methods. The standard method is this one. This is using a Hertel's exophthalmometer. And this is actually a crude method that we use in clinical practice using the ruler. This is the ruler method or the Lutz method. So with this, you measure from the lateral orbital rim and to the most anterior portion. So up to 2 centimeter is up to 1.5 to 2 centimeter may be normal, and more than 2 centimeter you can say that the proptosis is present. So that is how we clinically evaluate, but it is always better to have a formal ophthalmological examination done, because there are so many aspects to be looked into. You have to look whether the eye movements are restricted, you have to formally document the visual acuity, you have to have a fundus examination, and if required, the patient need to undergo a CT scan and MRI scan also. So if you suspect thyroid associated orbitopathy in a patient with Graves' disease, it is better to always get an ophthalmology consultation or a specific endocrinology consult. About the clinical course of thyroid associated orbitopathy. So if you consider this is the image A and this is the image B. If you compare image A and image B, there is appreciable difference between the two. First, we will look at what are the similarities. So this eye has got lid retraction, that is obvious, and maybe a mild proptosis also. Mild proptosis, which is not very apparent in this image. But when you look at the image A, you can see there is definite lid retraction, there is proptosis, and the most striking feature is the redness and congestion of the eyes. So this is the different spectrum of severity and clinical activity of thyroid orbitopathy. So when you describe an eye suffering from thyroid associated orbitopathy, we use two terminologies. One is the severity of the disease, and second is the activity of the disease. So severity of the disease means how much proptosis the patient is having, how much retraction the patient is having, is there any eyelid swelling. So these are the things when you look at the severity, or whether the patient is having any vision compromise. So those are the things that you look in the severity. Whereas in activity, we look at whether the patient is having any pain in the eyes, any redness in the eyes, and edema in the eyes. So it is clear that activity means inflammation, which is an acute process, whereas severity is a chronic process, because the proptosis and lid retraction would take some time to progress, whereas activity, it is an acute process. It is important to know that it is the clinically active disease which responds to immunosuppressant therapy. We use a number of immunomodulatory therapies for management of Graves' orbitopathy, and only if the patient is having an active disease in the form of pain, redness and edema, then only the immunomodulatory treatment will be effective. So for example, if you give immunomodulatory treatment with glucocorticoids or with rituximab or with azathioprine or with mycophenolate mofetil, the IA, this eye will respond by reduction in edema as well as reduction in redness, and whereas IB will not respond because there is no clinical activity in the IB. There is no edema, there is no pain, or there is no redness. So that is a difference in management with regards to the thyroid ophthalmopathy. So you must have learned in your undergraduate surgery classes about a number of named signs in thyroid ophthalmopathy. So it is important to learn a few because I will list out. Here is a list of 28 or 29 named signs in Graves' ophthalmopathy. It is impossible to learn and remember each one of them. So I will list out which are the most important and the commoner named signs that you should know. First is the Dalrymple sign. You have the Dalrymple sign, which is nothing but lid retraction. So that one you should know. Second is the Von Graves sign. So Von Graves sign, all of you must be knowing how to elicit it. It is the lid lag. When you ask the patient to look downwards, there is a lag between the eyeball and the eyelids. The eyeball will be suddenly able to come in terms by looking down, whereas there is a lag which is experienced in the upper eyelid. So that is the Von Graves sign. And third is the Stellwag sign. So the Stellwag sign is that because the patient will have a staring look and there will be infrequent blinking. So that is the what we call as the Stellwag sign. Then you have Mobius sign, which is the poor convergence. So at least these 4 named signs you should learn and remember with regards to description of thyroid orbitopathy. And these are some of the examples of the pretibial myxedema. So you might be confused because myxedema is a term that we had associated previously with hypothyroidism. And what did we attribute the myxedema in hypothyroidism to? It is due to the increased TSH activity. Increased TSH levels will act on the receptors to produce myxedema. What is myxedema? It is nothing but the subcutaneous or the connective tissue deposition of glycosaminoglycan and other collagen and non-collagenous proteins. So similarly in Graves' disease, what is happening is the TSH receptor antibody has got a stimulatory activity. It will go and stimulate the fibroblast. So the TSH receptor antibody stimulate the fibroblast to increase the glycosaminoglycan deposition. So the increased glycosaminoglycan deposition will result in myxedema. So myxedema can occur in both hypothyroidism and hyperthyroidism. It is due to the TSH-like action on the orbital fibroblast. Similar change can occur in the extremity also, where you get clubbing of the fingers along with periosteal proliferation that we call as thyroid acropathy. So this is thyroid acropathy and this is pretibial myxedema. So the pretibial myxedema is the most common location for thyroid dermopathy. So shins are the most common location. In fact, this type of skin lesions are more common on the sites of trauma. So whenever you develop a trauma on some site, these dermopathy lesions are likely to develop in those with Graves' disease. So shins, so extensor aspect of elbows, dorsum of hands. So these are the common locations for thyroid dermopathy. So regarding the prevalence of these extrathyroidal manifestations, this dermopathy is present in less than 5% of Graves' disease patients, whereas acropathy is present in only less than 1%. So in fact, it is the rarest form of extrathyroidal feature in a patient with Graves' disease, and thyroid ophthalmopathy can be present in up to 30 to 50%. So it doesn't mean that 50% of the Graves' disease will have clinically apparent proptosis or lid retraction. It means that if you look at the CT images of the orbit of all patients with Graves' disease, there is some degree of extraocular muscle enlargement. So we diagnose the thyroid orbitopathy based on the CT or an MRI by the characteristic enlargement of the extraocular muscle bellies with sparing of tendons. So in thyroid orbitopathy, thyroid associated orbitopathy, there is involvement of muscle bellies. Muscle belly size increases, tendons are spared. So this is the characteristic picture, and the most common extraocular muscle involved is the inferior rectus followed by medial rectus. And isolated lateral rectus involvement is a pointer against the diagnosis of thyroid orbitopathy. It is not thyroid associated orbitopathy, because there are several other infiltrative diseases like sarcoidosis or IgG4 related orbital pseudotumor. Such conditions are more likely to present with lateral rectus involvement, whereas in thyroid orbitopathy, isolated lateral rectus involvement with sparing of other muscles is extremely unlikely and is a pointer against the diagnosis. So these are some of the points regarding the extrathyroidal manifestations of Graves' disease. So how will you diagnose a patient with Graves' disease? Most of the points we have already discussed. We have the clinical parameters from the history, from the examination, as well as the routine biochemistry. We have the classical triad. We have the classical triad for the diagnosis. Then biochemical, you will have reduced TSH, increased T4 and T3, just like the typical thyrotoxicosis. And when you look at the T3 by T4 ratio, it will be more than 20, which helps to differentiate it from some cases of thyroiditis which can mimic it. Then you have the gold standard investigation, which is the TSH receptor antibody, which has a specificity of around a sensitivity of 95% and around 98% specificity. So it's an extremely useful investigation with regards to diagnosis, and it has got other importance also, and that we will discuss shortly. And you can do a nuclear imaging also for diagnosis, where you will get diffuse symmetric uptake in both the thyroid lobes. So this is how we establish the diagnosis of Graves' disease. So TSH receptor antibody, we have already mentioned there are three types of TSH receptor antibody. You have the stimulatory antibody, you have the blocking antibody, and you have the neutral antibody. So stimulatory is what is present in Graves' disease, blocking in Hashimoto's thyroiditis, and neutral can be present in both Graves' disease and Hashimoto's thyroiditis. So what the sensitivity and specificity we have already discussed. So we don't do TSH receptor antibody for diagnosis in all patients, only in those with certain equivocal conditions. For example, in patients with orbitopathy without thyrotoxicosis. So in patients who have thyroid eye disease like findings with proptosis and typical muscle involvement, but there is no goiter, the thyroid function is euthyroid, then you have to confirm the diagnosis. For that, you can use TSH receptor antibody. Then Hashimoto's with orbitopathy, you can use in diagnosis, and some cases of typical Graves' disease diagnostic confusion also, you can use TSH receptor antibody. The nuclear imaging, we have already mentioned, there is bilateral, symmetric and diffuse uptake. Diffuse uptake. Which are the nuclear imaging studies that we use? One is the radioiodine study. Radioiodine study, and also the technetium-99 uptake study that we have discussed previously. And absent salivary gland uptake in the imaging. So the physiology and how this imaging is taken, everything we have already discussed. So this is the one of the examples of image. This is the radioactive iodine. This is the radioactive iodine and this is the technetium-99 scan. So it's more or less the same actually. The appearance, you can see the bilateral, symmetric and diffuse appearance in Graves' disease. In euthyroid, you can see the bilateral uptake, but it is not as intense as seen in Graves' disease when you compare the two, and you can actually quantify the percentage of uptake that is also given in the report. By that way, you can differentiate between a normal uptake and a pathologically increased uptake. So that is euthyroid, and in thyroiditis, there is absent uptake. So this is how we make a diagnosis of Graves' disease. Now, just we will look at one of the case scenarios. A 23-year-old married woman presented with palpitation and tremor of 6 months duration. So obviously, she is having clinical features of thyrotoxicosis. TSH is reduced, total T4 is increased, total T3 is increased, and TSH receptor antibody is also increased. So we have no confusion with regards to diagnosis. It is nothing but Graves' disease. We want to identify the best treatment option. So which are the treatment options that is available for a Graves' disease patient?